So good day to you. Thank you very much for giving me the opportunity to present one of our latest papers about the preclinical evaluation of PSMA-specific tracers for prostate cancer radionuclide therapy. I'm Julie Nonnekens, and I'm a group leader at the Erasmus MC in Rotterdam, the Netherlands. So first I would like to give a small introduction about the work of my lab. We work on radionuclide therapy, targeted radionuclide therapy, and we use two approaches. So we want to understand what the therapy is about and use this knowledge to improve treatments. So for example, we're looking at tumor responses, normal tissue toxicity, and also characteristics of the peptides that were used for targeting vectors. And this knowledge we can use to improve the systemic treatment with radionuclide therapy. For example, by choosing a different radionuclide, by designing combination treatments, or by changing the peptide. And for this, we use different modalities, a lot of imaging modalities. For example, immunofluorescent and live cell imaging of living cells. We do screens to find, for example, synthetic lethality relationships between novel drugs. We also do a lot of animal studies in which we study tumor growth, but also accumulation of the radionuclides in specific places in the tumor or in organs. And we also do in silico analysis to optimize dosimetry methods. So to talk about the paper for today, it's about prostate cancer, which is a major health issue with 450,000 men diagnosed in Europe in 2018, and it's 12% of all cancers in the Netherlands. At the moment, there are many treatment options, and especially for local prostate cancer, the 5-year survival rate is very good, almost 100%. But when the prostate cancer metastasizes, this 5-year survival rate drops to about 30%. So this really shows that even though we have many treatment options, we can do better, we have to do better. One of the most novel approaches for treatment of prostate cancer is the targeting of PSMA. PSMA stands for prostate-specific membrane antigen, which is a transmembrane enzymatic protein. It's expressed on the prostate epithelium, but it's severely, vastly overexpressed on prostate cancer. And this has a high correlation with disease progression, meaning that during advanced disease, there's a higher level of PSMA expression. Here you can see a clear picture of a patient treated with PSMA labeled with lutetium-177, a beta emitter, and a patient where you can see major lesions in black after the first treatment, and after different cycles you can see the lesions appearing, really showing the power of this novel treatment modality. So what we did in our study to compare different PSMA-specific tracers, because at the moment various are developed and some are in clinical testing as well, but none have been compared preclinically to show which one actually is the best. This is work done by a PhD student in the lab, Eline Ruigrok, and she evaluated 3 PSMA-specific tracers, PSMA-617 and PSMA-I&T, which are applied in the clinic, and GVZ007, which is a nanobody developed in the Erasmus MC at the Department of Urology. So we looked at binding affinity, biodistribution, and also healthy organ binding to do a recommendation of the best tracer. So we examined the uptake of the different tracers labeled with lutetium-177 in different cell lines. And there you can see that PSMA-617 always has the highest binding in these in vitro cultured cells. But furthermore, we also performed autoradiography on fresh frozen samples of prostate cancer PDX material. And you can see the darker the picture, the more tracer is bound. And when you look at the PSMA positive PDX, there's a lot of binding of the PSMA-617 and I&T, a bit less of the nanobody, and the PSMA negative PDX, there's no binding. And this can also be quantified where you can see comparable results with the cell experiments that we have the highest binding with lutetium PSMA-617 than with I&T, and the lowest with the nanobody. What we also did was IC50 displacement assays, where we displaced the radiolabeled compound with blocks of the different other compounds. And what we found is that PSMA-617 has the lowest IC50 value, which means it's most favorable. And what we also found is that PSMA-617 and I&T can block each other. So this is not strange because they have the same binding site for PSMA, but the nanobody was not able to displace or be displaced by the 617 and I&T. So we came with this model, and these two can displace each other, but this one is separate. And this might have indications when developing, for example, a novel targeting agent, because it has apparently different binding sites. However, what we also saw is the nanobody has a much lower binding affinity, and therefore it's not really applicable for a clinical application, and that's why we also discarded it for further in vivo evaluation. So next we performed animal studies in mice, which were bearing a PSMA positive PDX xenografts. And when we analyzed the animals with a vector SPECT CT at different time points after injection, this is lutetium PSMA-617. You can see accumulation here in the tumor, still a bit in the kidneys and a bit in the bladder. And then looking at 8 hours and 24 hours after injection, you can really nicely see only accumulation of the tracer in the tumor. So comparing this to lutetium PSMA-I&T, you can see at 4 hours after injection, there is nice accumulation in the tumor, but there's still massive amount of radioactivity in the kidneys and the bladder. And also at 8 and 24 hours after injection, you can see that this is going down, but still there is a lot of radioactivity at the normal organs, which is not favorable generally for radionuclide therapy. So we further analyzed these tumors for many animals. And we did a biodistribution, so we measured ex vivo the accumulation of the radioactivity in the tumor, in the kidneys, but also the other organs. I'm just showing these for the sake of simplicity of this presentation. So you can see that there's accumulation in the tumor, and with the lutetium-617, there's hardly any accumulation in the kidneys. Looking at the PSMA-I&T, there's about the same level of accumulation in tumor, but it's much higher in the kidneys. So then we look at the tumor to kidney ratio, which is increasing over time for the PSMA-617, which is favorable, but it's much lower for the PSMA-I&T. And this again illustrates the non-favorable kinetics or biodistribution for PSMA-I&T. So besides measuring these organs after injection in the mice in the whole organ level, we also performed autoradiography on the organs after cutting them in small slices. And here, when this is quantified, you can clearly see that we also have again the same tumor to kidney ratio as what we found for the whole organs, confirming again that indeed the PSMA-617 has a much more favorable profile compared to PSMA-I&T. What we also did was measuring the level of DNA damage induced by the radionuclide, because that's the mechanism of action. Lutetium-177 induces DNA damage, which will lead to cancer cell death in the tumors. So what we did, we measured two markers for DNA damage in the tumor, gamma H2AX and 53BP1, which are markers for double-strand breaks. And we already saw that there's not a lot of difference between the uptake of lutetium-177 between the different two tracers. And indeed, if we look at the level of DNA damage, there is not a lot difference between the two tracers. So here, this is for 53BP1 and this is for gamma H2AX. This was expected because the same level of radioactivity would lead to the same level of DNA damage. What we do see, and that's also what we found in other studies, that there's large heterogeneity between animals, but also within tumors. And this, we do not know for this specific study what is causing this, but this might be important when designing treatment modalities, for example, for patients, because parts of the tumor might be targeted differently from other parts of the tumor. So, of course, a mouse is not a patient. So we also examine tissues from patients, from healthy persons. So we examined healthy human kidneys and healthy human salivary glands, the two main dose-limiting organs in patients with autoradiography. So we treated those in vitro with the lutetium-177-labeled tracers. And what you can see is that in the kidneys, there is a lower uptake or lower binding of the 617 compared to the I&T, here also quantified. And this is what we also see in the salivary glands. So this confirms also what we found in our mice, that the PSMA-I&T has a higher binding to the normal tissues. And we do not see a difference in the binding to the tumors in vitro. So this confirms that the findings from mice are also true in humans, which is not favorable for the I&T. So with that, I would like to come to my discussion points from this paper. What we found in the beginning, we looked at the 3 different tracers, PSMA-I&T, PSMA-617, and a nanobody. And a nanobody could not displace or be displaced by the 2 other tracers. However, also the nanobody demonstrated a very low tumor binding, and therefore we discarded it from further analysis. But this might have implications for further clinical development. Furthermore, we saw that PSMA-617 and PSMA-I&T showed similar tumor binding and induction of DNA damage. So based on effectivity, these 2 tracers are very comparable. However, the PSMA-I&T showed very high renal uptake in the mice and also a high binding to the human salivary gland and the renal tissues, which even though the effectivity is probably comparable, the toxicity is much the toxicity profile is not as good for I&T as it is for 617. So from our study, a preclinical study, we can conclude that lutetium-177-labeled PSMA-617 is the most favorable tracer, which can be explored for further use. So with that, I would like to thank all the people that were involved in the study. So the people in my lab, and especially Eline Rijgroep, who did most of the work, the people on the paper. And this was a collaboration with the lab of Wietske van Weerde and Marion de Jong in the Erasmus MC. And of course, I would like to thank all the financial support, especially KWF, who sponsored this particular study. Thank you for your attention.